as we open another virtual morning report session. For those of you who I haven't had a chance to meet yet, my name is Jack. I use he, him pronouns. I'm one of the CP Solvers team members, and I'm super stoked to be doing this Wednesday VMR with the one and only Dr. Sharmeen Shakarchian. Sharmeen, how's it going?
Did you just call me Dr. Sharmeen?
I did.
Wow. I suddenly felt like I need to wear my white coat and like this is a grand rounds presentation. Hi everyone, it's just so good to be here on a Wednesday. One of my joys in life is to give Jack a little bit of a hard time and make him blush. So that was my poor attempt at doing that. Well, we're so excited to be here and like chat medicine, have fun, and we would love for anyone who wants to discuss to join us. We would love to have a volunteer. It's gonna be fun. It's all for learning purposes. It's a safe place to chat, learn together. And Deborah has a case that she's going to present to us. So we are ready to go.
We are just going to have to wait in silence for two people to volunteer to discuss with us. And if I lower my voice a little bit, we may be able to get someone to volunteer. Whether this would be your first time or your 50th time or your 500th time discussing a case, please consider volunteering to join us. The alternative option is just listening to Sharmeen and I, which I think everybody here will agree is the lesser of the two options.
Yeah. And I would say is like so normal to be nervous. I still get nervous all the time. Discussing cases anywhere, anytime, whether it's in VMR, whether it's in morning report in our institution, or is it just like a written format of a CPS, nervousness is good. Even a little bit of it. It just means we care. So we care to have fun. That was my deep reflection for today, Jack.
I know. I always grapple with it, right? Of like, because like I am so uncomfortable with silence. Maybe there would be, we'll push a volunteer forward if we're silent, but then I get uncomfortable. So I start talking the way that I'm doing now.
Chief, you was helpful in helping me be more okay with silence.
Yeah. Oh, amazing. Hans, thank you so much for volunteering. We just need one more. Who wants to join Hans? Breaking the ice here. Anybody interested in joining Hans? Oh, Reza. All right. Amazing. Thank you so much, Reza. Well, Hans and Reza, we are very lucky to get to discuss this case with you. Maybe we can just, before we get started, ask the two of you to unmute and introduce yourselves. Hans, why don't we start with you?
Yes, I'm a more or less recent graduate from Ross University. I was a clinical skills facilitator, and right now I am working in the hospital here in Germany just for a little while as a guest to see how things are running, and hopefully I'll match somewhere either in Canada or in the States. So the CARMs, the documents have to be sent off by January 31st. So it's getting close for our match in Canada now.
Well, we are crossing our fingers for you. That's very exciting.
Yay, Hans. We're rooting for you.
Thanks.
And Reza, thank you so much for volunteering. We'd love to learn a little bit more about you.
Sure. My name is Reza. I'm a fourth-year medical student at the University of Toronto. I'm applying to both ERAS and CARMS, so also aware of the CARMS deadline coming up, and applying to internal medicine.
Awesome.
Reza, we're so excited to have you. And is that a Persian last name?
It is, yeah. I'm Iranian. I was born in Iran. Grew up in Canada, though.
Yeah, I'm Iranian too.
Oh, really?
Like, I recognize
There we
that.
go.
I was like, I recognize that last name.
Awesome. This is my first time doing this, by the way. So
We'll have a lot of fun. You do not worry.
All right. Well, now that we have the guarantees of fun, two excellent case presenters, Deborah, we will turn it over to you to get us started with the case. Antonio, feel free to take over the screen anytime. And Deborah, the only thing we ask before you get started with the chief concern is for you to also introduce yourself to everyone here.
Hi, everyone. My name is Deborah. I have been here has 1 year, and now in the beginning, I was a little ashamed and just listen. Now I'm participating more. So if you are in the background feeling ashamed, I invite you to be with us. It's a safe place to learn and nothing. I have been ashamed for a while, and now I feel more confident. I think everyone has their own time, but I want to motivate it. So let's do it.
Thank you so much for sharing that, Deborah. I will say the more there is a direct relationship between the amount that you participate in VMR and the amount of fun that I have being a part of VMR. So that goes for everybody. The more that you all participate, the better it is for all of us. So thank you for sharing that. Charmaine, how do you wanna pair up?
Take the first, I'll go, friend.
All right. And then let's see, Hans, do you wanna team up together?
Yes, we can team up together.
That sounds good. So Hans, you and I will be taking the first aliquot.
Okay.
Okay, I will start. The chief concern was a 66-year-old female with short of breath and dry coffee for 1 week and a half. I can give a little bit more information, or I can stop here. What you prefer?
Why don't you go ahead and give us a little bit more of the HPI here?
Okay. The history of present illness: the patient denied fever, chills, chest pain, orthopnea, paroxysmal nocturnal dyspnea, and a little bit of the past medical history. The patient has atrial fibrillation and ischemic cardiomyopathy with ejection of 50%. That was before COVID. Medication: the patient takes amiodarone 200 milligrams twice a day. That started 6 weeks from the admission, and denied any allergies. And I'll stop here.
Amazing. Deborah, thank you so much. I love the focus of the HPI here in terms of like just giving us only the things that we need to work with to understand shortness of breath. Hans, looking at this stuff that we have here,
Yes.
how are you thinking about this case so far?
With the information given, and it's already been mentioned in the chat, first of all, we are thinking about amiodarone, but I don't know for how long she's had amiodarone, but it's pulmonary fibrosis is one of the possibilities. Another possibility would be, and it hasn't been mentioned, that's vascular. Is she on a medication that's an anticoagulant? So I was thinking about even small thrombi in the lung, which can cause shortness of breath, not necessarily a full-blown pulmonary embolism. Then among the infectious diseases, and that was mentioned in the chat as well, we can consider the possibility of a pneumonia that is coming up from some kind of recent infectious illness, but she denies fever. And then, of course, there is a possibility for malignancy, for heart problems. She has atrial fibrillation, so maybe She has something like a congestive heart failure, but she denies orthopnea and paroxysmal nocturnal dyspnea. So this is all very difficult to reconcile, but it's a possibility that we would like to put on our differential.
Hans, I love it. I think you just took the approach to dyspnea in terms of thinking about the broad categories of disease that can cause dyspnea, whether it's a pulmonary problem, a cardiac problem, or a vascular problem. And then you did a brilliant job of drawing a straight line between each of those categories, right? Lungs, heart, blood vessels, to potential etiologies that this patient could be at risk of developing. And just to sort of expand our thinking a little bit as we think about this person who has sort of a acute to subacute course of dyspnea, I will say that like two useful ways of helping to narrow into which organ system is causing someone's shortness of breath is to look for sort of two patterns of disease. Is one, we can look for symptoms of volume overload, and that can very quickly help us start to sort of localize the lesion into the cardiac system, right? So is there symptoms of exertional dyspnea, weight gain, orthopnea, PND, lower extremity edema? If we see those associated symptoms, right, those sort of friends of the patient's shortness of breath, then we can start to quickly localize into a cardiac problem. And exactly as you said, Hans, atrial fibrillation may be on the hook, or the underlying ischemic cardiomyopathy may be on the hook. The other sort of, I think, historical pathway to explore is not only symptoms of volume overload, but also symptoms of systemic inflammation, right? Is there fever, chills, accompanying weight loss, or night sweats, right? Whether we have an acute or subacute or chronic course of systemic inflammation can help us think about an underlying pulmonary pathology. And that's because, right, if we have shortness of breath plus volume overload, that fits very easily with symptoms of the cardiac system. Whereas if we have symptoms of shortness of breath plus systemic inflammation, we can start to potentially localize into the pulmonary system, whether that's something that's going to be related to a pulmonary infection, a pulmonary malignancy, or in less common but certainly plausible circumstances, a pulmonary manifestation of a systemic rheumatologic disease. Now, sometimes we are stuck in a case exactly as this one where we have neither of those. And as you pointed out, Hans, right, we have to sort of reconcile the fact that we don't see symptoms of volume overload and we don't see symptoms of systemic inflammation here. And I think that can be from one of a few reasons. One of them is that we have to acknowledge that our history is going to be limited, right? Even if we don't see symptoms, or even if we don't hear a history of fevers, chills, night sweats, or symptoms of volume overload, we still have way more diagnostically weighty data coming in the physical exam and in likely what is going to be at least a chest x-ray to evaluate the shortness of breath. And so even if these things are absent in the history, if we see a consolidation on chest x-ray, a mass on chest x-ray, an elevated JVP on exam, then all of a sudden we can help to localize further. And I think that like this dilemma really highlights how the history can be both helpful, but also we're limited in the distance that we can take a case, particularly for shortness of breath with the history alone, because almost all cases of shortness of breath are going to center on a focused evaluation of the cardiac system, a focused evaluation of the pulmonary system, and then also at times, right, if both of those pan out negative, a more focused evaluation of the vascular system, particularly looking for a thromboembolic event like a PE. So I think where we're at in this case is if we take that sort of normal pretest probability of lungs, heart, vessels as sort of like the top three categories, right? Maybe the absence of inflammation makes an inflammatory pulmonary disease a little bit less likely. The absence of symptoms of volume overload makes a cardiac disease a little bit less likely. And then maybe we're starting to think about bringing something like a PE into the fold. But again, it's going to be hard to make a ton of progress on that without looking at the physical exam and at least some of the basic imaging studies. But I think all of the hypotheses that you lined up, Hans, are spot on in terms of thinking about, is the AFib on the hook, or is potentially the amiodarone on the hook, or are we going to be dealing with a vascular event as well? So I'm excited to see where you're going to take us next, Deborah.
Yeah, great discussion, guys. Going for the vital signs, The patient has a temperature of 98.7 Fahrenheit, a heart rhythm 85, respiratory 32, blood pressure 135 for 80, a saturation 87% on air. And then the physical exam, we have in the pulmonary bilateral coarse crackers with no wheezes. The cardiovascular abdomen and skin was normal, and the patient didn't have signs of fluid overload. And then I can go a little bit more and tell the chest X-ray, like that showed a diffuse bilateral interstitial infiltrate, and the CT without contrast showed a ground glass opacity. And I'll stop there.
Boom. Thanks, Deborah. This keeps getting better and better. Reza, I'm so excited to discuss with you. What are your thoughts? Maybe we can start with the exam. What is jumping out to you? What are your thoughts so far?
I mean, when we're discussing like shortness of breath, as you mentioned, like the cardiovascular system, you know, it's normal limits. There's no no mention of an S3, no mention of any volume overload from that perspective, no new murmurs. So really, like cardiovascularly, we're a little bit less inclined to go down that path. Additionally, pulmonarily wise, we're seeing like bilateral coarse crackles without a wheeze. So like less so something like COPD or asthma picture, but more so maybe like infiltrative picture, especially with the low oxygen saturation on room air and the low respirate. The fact that they're afebrile and they're normotensive and their heart rate is normal kind of picks away from like things such as an infective process that could possibly be at play. And also the fact that they're not like tachycardic makes like something like a PE a little bit less likely, although, you know, can't rule it out for sure. And then all of the other components of the exam being within normal limits kind of takes away from maybe a more like some other like causes that could be at play, like autoimmune conditions that could manifest in other capacities like MSK wise, dermatological wise. Obviously, there's still more that we have to kind of go through, but I think that's from the exam perspective. I'm more towards a primary pulmonary cause that's kind of more swaying me.
Dude, Rez, that was fantastic, Reza. I totally agree with the things that you hone on to in terms of like thinking about the patient now being hypoxemic and also taking the lung exam and the chest X-ray and CT finding and build a differential from that. And I'm right there with you. And I think when people in general present with shortness of breath, I'm like, whether they have dyspnea or whether they have like hypoxemia or not is a good branching point for me. Because like, you know, if you have severe anemia, if you're just like asthenic and you have generalized weakness, like all of these things can manifest as shortness of breath. And then when we have hypoxemia, you're like, bang, now we have to explain there is a problem with oxygenation in the lung. And then the question is like where that problem is. And the other thing that is also good, whenever I see a saturation of 87%, there are a couple of things that I do. One is check my pulse ox and the wave just to make sure that I'm getting a good reading. You'd be surprised how many times you get called that like, hey, this patient has low oxygenation. And you're like, does it? And then go and you see the waveform is poor. So just to make sure to verify that patient is like hypoxemic. And in this case, for sure, we know this patient is hypoxemic. And then the question becomes like, hey, is there at any point do I have to worry about ventilation as well, or oxygenation is the major issues? And sometimes with ventilation issues, as you mentioned, like in COPD or COPD, like people have also tend to be hypercarbic. Those people tend to have very minimal oxygen requirement as well. I don't think we're having a problem with ventilation. So I think this is mostly a patient who's coming with hypoxemic respiratory failure as well. And then the exam is like super helpful, right? If the chest X-ray was normal, if the lungs make no sounds, then people would be more worried about vasculature, as you mentioned, like something like PE. But we have pathology within the lung parenchyma itself in the form of like the crackles that we are hearing, that now with the chest X-ray and the CT is translated into like these ground glass opacities. And so that kind of helped us focus into the alveoli themselves and like what is going on within the alveoli. I'm a simple person, to be honest. So the things that I think about what can happen within the alveoli is it water in them? Is it pus in there? Which water tends to be the most common, right? With like pulmonary edema. Then there's pus with infection that we worry about, like if it's like, the other thing is like blood, like DAH, you mentioned like autoimmune diseases. With autoimmune diseases, we'll see if like there's any anemia, if there's any other reason. As you mentioned, a lot of them is like the small vessel vasculitides, pulmonary renal syndrome that we worry about. We have a little bit less suspicion about it. And the other things that are less likely is like cells and proteins that also can get into there. To kind of like take a step back and thinking about for that framework in this patients, like infection is common. We live in the land of COVID, like viral pneumonias can cause ground glass opacities and all that jazz. So definitely evaluating for infection. The other things to think about with water is that we don't see, as you mentioned, like any other sign of hypervolemia to say like if this is heart failure exacerbation. I've been humbled with heart failure in general. Sometimes different people put their fluid in different places, especially like people with HFpEF. They have it's so much easier for them to get hypertensive and have pulmonary edema and then have suddenly developed shortness of breath. But the 1.5 week argues against that. So the next phase is like basically trying to figure out what this ground glass opacity is during your infectious workup. And I would still think about water a little bit in this case as well. Go from there. All right. Can't wait to hear the next.
Okay. And then the labs now, the white blood cells was 100,500, hemoglobin 13, platelets 3,160. The sodium and potassium was normal, creatinine 1.5. The bone was 41, normal cardiac enzymes, normal liver enzymes. And then the arterial blood gases present a pH of 7.5, a PaCO2 of 35.2, PaO2 69, and HCO3 of 28.2. And then the patient was 100% FaO2. So he gets worse with hypoxia and needed to be intubated. And then I can give a little bit more information. They did test for infections, blood cultures, fungal serologies, sputum, bronchoalveolar lavage, bacterial fungal, active-fast bacillia culture, PJP, PCR, HIV, and all negative. And I can give one more information. And they did a transthoracic echocardiogram that showed an ejection fraction of between 40 and 45%, mild left ventricular hypertrophy, and a grade 2 diastolic dysfunction. And I'll stop here, and the next aliquot we are gonna know the diagnosis. So.
Amazing. Deborah, thank you so much. Before we dive into discussing this, I just wanted to clarify the white blood cell count. Was it 100,000 or 1,500?
100,000.
100,000.
So an incredibly high white count, is that right?
No, wait. let me check. Maybe I said wrong.
No,
I'm
no
not
worries at
super
all.
good-
No worries at all.
I'm not super good at numbers in English. Wait a minute.
If you can also type it too.
Okay.
Or-
wait a minute.
And if you like, oh, it's actually normal, that's also, you can
It's
just tell us.
normal. It's
It's normal.
Oh, yes.
Perfect.
Sorry.
Perfect. That's super helpful because that will, I was getting ready to go into the whole world of like leukostasis syndrome and acute myeloid leukemia, but we will tailor our discussion to somewhere else. And I will let Hans lead us in tailoring that discussion. Deborah,
We
thank
can
you.
still talk about it.
I mean, we
Take it
could, yeah,
long.
maybe we can sort of come back to that at the end. We can wax poetic about the myeloid lineage. But
You got
Hans,
very excited. I just want to support you.
I know, thank you. Hans, how are you thinking about this case now, right? Deborah has given us fantastic information that includes this very thorough infectious workup that we can now think about layering on to the absolutely fire DDX that Charmaine and Reza gave us for the ground glass opacities.
Something is wrong with the lungs, but I can't really tell what it is. At first, when I saw the 100,500, so extremely high white blood cell count, I was thinking maybe it's pointing towards a malignancy or something, but that's not the case. It's normal. So the only unusual thing that we have is the chest X-ray with diffuse bilateral interstitial infiltrates. And now I'm not sure what this might bring. I mean, we have no infectious etiology discovered at this stage. So no fungal infection, PCP and HIV is all negative. But he had to be intubated as if he has acute respiratory distress syndrome, something like this. And I'm now thinking what could have caused this kind of distress to the patient. And I have no idea at this stage other than maybe a chest CT showing greater resolution of what's going on with the parenchyma of the lungs. Does he have, yes, it's a female. Does she have some malignancy in her lungs? That could probably cause some infiltration as well, but we should have seen something like a mass in the chest X-ray, so that doesn't fit either. So I pass on the mic to somebody else.
Well, Hans, I wish that you weren't passing the mic to me because I am also in this state of same uncertainty as you are. But I think, you know, right, like you, one of the most important things we can do in reasoning through a case is actually not get to the correct diagnosis, but it's actually represent the problem correctly. Because if we can consistently represent the problem accurately, then we set ourselves up over time to be able to come to the final diagnosis more often than not. And really, once we have the problem represented correctly, it really becomes a task of probabilities rather than being able to nail the final diagnosis. And I think in this case here, right, we without a doubt do not have all the information that we would need to make a correct final diagnosis here. So really all we can do is do exactly what you did, which is represent the problem in an absolutely spot on way, which is what you said, that this is an abrupt, like progressive, escalating, severe respiratory distress syndrome in the absence of, at least so far, signs of infection. And I think that is a phenomenal problem representation for sort of where we're at. And so now if we ask ourselves, like how can we tease through this problem? I think the most helpful way to do is actually to look backwards in this case. And the two places that we can look backwards in this case are to the CT findings and the DDX that Charmaine and Reza gave us, and then also to the past medical history, because I think both of those things can help inform what could be going on in the lungs, right? So Charmaine and Reza taught us that diffuse ground glass opacities can be pus, blood, water, or cells. And I think we need to just go through each of those possible categories and frame the probability, because all diseases in each of those categories can give us the problem that you represented so well, Hans, right? And so if we think about pus, right, certainly there's a number of different infections that can give us a diffuse ground glass opacity pattern. That's usually going to be viral infections. And I would say that like a respiratory viral panel or PCR testing off of sputum can be pretty reliable there, right? So do we see things like respiratory syncytial virus or RSV, It sounds like this case was in a pre-COVID era, right? But this would be totally compatible with COVID. So COVID testing would be helpful. Do we see things like influenza as another entity that can cause diffuse ground glass opacities? And then in the immunocompromised host, as Deborah really helpfully told us, right, we don't see things like pneumocystis pneumonia, right? So I think, right, based off of the data that we have here, most of the cultures data has been negative so far, which decreases the very high pretest probability of an underlying infection, right? But I note that we don't quite yet have maybe some of the full viral panel testing, but if that ends up being negative, I think we at least can reasonably reduce the probability of an underlying infection. One thing that I will note is that it does depend a little bit about where these cultures came from. So if we're just sampling it from something like sputum or a tracheal aspirate, those can both be helpful. And if we want to really dig into whether or not we can falsify the infectious hypothesis, a bronchoscopy with bronchoalveolar lavage is going to be probably the most sensitive way for us to explore that. And in somebody who has progressed so abruptly, as you mentioned, Hans, I think that is a place that we might consider going here, right? But that's sort of how we can handle the infectious category, thinking primarily about viruses, maybe some atypical bacteria like Legionella, and then in the immunocompromised host, thinking about organisms like pneumocystis pneumonia and other fungal pathogens. Now we get to go into the category of blood and ask ourselves, right, do we see a signature of an underlying rheum disease like Charmaine mentioned, primarily something that's going to be a vasculitis. A vasculitis is normally going to have systemic features, so things like fever and chills and weight loss, and we usually would expect to see other organ involvement, so things like the nervous system or the renal system, which we don't necessarily see a signature of glomerulonephritis here, right? So I think that sort of the base rate of that is quite low, and we haven't really seen the features that bring that into the fold. I will say anti-GBM disease is one of the underlying vasculitides that can have primarily pulmonary manifestations only. And so this is sort of another reason why something like a bronchoscopy could be quite helpful here, because if we see serial increases in the red blood cells on bronchoalveolar lavage, right, we then can go into the diffuse alveolar hemorrhage category, which again could be compatible with this pattern. But I think so far, right, that's not seeming very likely. That's not seeming super likely yet, but we haven't necessarily taken that off the list either. The next category is water, and I think that Charmaine and Reza nailed the conversation around heart failure here. And then we get into the category of cells, and this is where we can think about potentially going back in time here and asking ourselves, is there any way that what we're seeing is actually just a immune or inflammatory response or cells driving this pattern of really interstitial changes? And I think a number of you in the chat mentioned that amiodarone, right, might be a link here in terms of thinking about the underlying pulmonary toxicity, right? Amiodarone can cause a number of different pulmonary toxicities. The most common one is going to be an interstitial pneumonitis, but there's also other manifestations of amiodarone pulmonary toxicity, things like eosinophilic pneumonia, organizing pneumonia, ARDS, or DAH. And then we can also see things like pulmonary masses and pulmonary nodules, right? So the spectrum of amiodarone-induced pulmonary toxicity is actually quite broad. The one that we most commonly see is an interstitial pneumonitis, but some of the other things on the list, whether it's masses, which we don't see, or alveolar hemorrhage, which we may be dealing with, but it seems unlikely, both of those can be on there as well. But then the question becomes, well, how do we get to a diagnosis of amiodarone-induced pulmonary toxicity? And it really is a diagnosis of exclusion, and the things that we exclude is all of the other things in the ground glass opacity list. One thing that can be helpful to look for on the cross-sectional imaging is you can actually sometimes see areas of brightness on the CT scan in places like the liver and the spleen, because the amiodarone can actually accumulate in those regions as well. So if we happen to see those on the cross-sectional imaging, it might continue to make a case for amiodarone-induced lung toxicity, but that is not necessary to make the diagnosis. In order to make the diagnosis, we have to exclude all of the other things. And so I guess I would say where I would go from here is sort of continue to be open to the categories that Charmaine and Reza and Hans mentioned: infection, blood, water or ultimately cells, which can also include malignancy. But I think if those things are excluded, we have a plausible hypothesis for amiodarone-induced interstitial pneumonitis, given that both the exposure to the med is there, the tempo of the progression is also there, which is where we see things like this sort of crescendoing symptom, or the indolent symptoms that can crescendo into severe lung disease. And then the one other thing that I think is also super interesting here is this patient's blood gas, because we notice that she has what seems to be a combination of a respiratory and metabolic alkalosis. And I do wonder if actually at baseline, she has a bit of a respiratory acidosis and is now in the setting of her acute respiratory distress blowing off CO2. But actually the 35 seems like a small gap from normal. So maybe she lives a little bit higher in her CO2. So is there potentially underlying lung disease that was pre-existing that's now being exacerbated? And that would also be potentially compatible with amiodarone-induced lung toxicity, because again, it can kind of smolder along and then crescendo like we see here. And so I think that sort of is the route that I would think about going here in terms of exploring those pathways. And then if all of those, again, pus, blood, and water end up being excluded, then I think we have a potential hypothesis of the amiodarone here. Deborah, take us home. What happened next?
Okay, and then now they did the biopsy and then of the lung and showed a patch interstitial pneumonitis with foci of interstitial fibrosis, reactive hyperplasia of pulmonary macrophage, and many type 2 pneumocytes, and we spread foamy cytoplastic change. And the diagnosis was amiodarone toxicity. Congratulations everyone that said in the chat and for discussion. And then the patient started with 6 milligrams of prednisone, was extubated, and went home on 2 liters per minute oxygen. Thank you, guys.
Oh, Deborah, what a fantastic case. And Jack, Hans, Reza, y'all are freaking brilliant. Yeah, a question for you, Deborah, was the amio medications, usually like this pneumonitis happens within the first year. Just out of curiosity, do you know if it was a new medication for this patient?
Sorry, again?
Yeah, so a lot of this acute pneumonitis type pictures usually happens within the first year of people getting started on amio. So I was just curious to see if you know that this was a new medication for the patient or not.
Was like the patient started 6 weeks before the medication.
6 weeks before. Gotcha. So yeah, that actually, it's a really, really good time frame for the pneumonitis that happens with amio. I just want to, Hans, Reza, any thoughts, any questions, any reflections?
My reflection is, first of all, it's the first time that I see a patient with amiodarone-induced pulmonary fibrosis and how serious it is. It's a good learning experience. Thank you.
Yeah, this is honestly like the most acute I've also seen it. The cases that I've seen is like mostly kind of like subacute, chronic, extra findings like patients' oxygen requirements slowly increasing. This is quite, I agree with you, a drastic presentation of amiodarone induced, which kind of makes sense with the time frame. It's been 6 weeks. I think her immune system really didn't like it. Reza, Jack, any other thoughts, reflections?
It's just like, yeah, this is the first time I'm kind of seeing it in such a dramatic picture as well. It's just interesting because, we always prescribe medications, and even things that are rare, they happen to somebody out there. So it's always important to recognize the possible side effects of all the medications, even if they are rare, and debate whether or not for each person, if it's the right choice. And I also wonder if they're still in AFib or not. and if it actually did convert them, or if it wasn't appropriate, and then like what they changed into, like were they put on rate control and were they put on anticoagulation, things like that.
Yeah. Reza, I love it. Speaking like a true internist to be. No, I think that's such a fantastic point about thinking about medications that we start. And just so much of medicine is like iatrogenic, the things that we do to patients, to be honest. And especially with amio, it's one of the drugs that I have love and hate relationship with, that it works so great for arrhythmias and it's so terrible over the long time. You know, the thyroid dysfunction that it can cause, lung issues that it can cause. So definitely a medication that we just like have to be careful when we start, and always like kind of like similar to steroids, like you put it on thinking about, okay, when can I take it off? And it has a really, really long half-life. So even with stop it, this patient is going to have amio in their system for a long, long time coming. And yeah, and I think in terms of like the AFib management, like, you know, calculating the chatbot score, making sure that they're anticoagulated or not. And also like, now I think like with AFib, people are leaning towards a more rhythm control. I think like we went back to rate control, and now cards is mostly want to do rhythm control. And I would wonder if like somebody like him, you know, a cardioversion or ablation or something might be in their future if they can't tolerate either rate or other rhythm control agents. We see a lot of the feather light. I don't know about you, Jack, but our cardiologists really like to develop the feather light loads people too. So thankfully, I think this patient still has some options for AFib. Jack, anything to add?
No, I just think that this was, I just want to thank Deborah for bringing, I think just like the way that you presented the case, the way that you filtered the data, it just set it up for such a fun case to discuss, and like the different stop points along the way and everything. I just absolutely applaud. And I think I wanted to highlight one teaching point that you had made earlier, Charmaine, which is like how difficult it can be sometimes to pick up amiodarone toxicity in the earlier stages, because it can look a lot like or feel compatible with heart failure. Like, I'll be honest, I heard the physical exam and I was like, oh, look at that. Like, we're going in the heart failure direction. But I think both you and Reza picked up on the fact that like, well, we have crackles, but no other signs of volume overload. And so I think like a take home point for me was, again, like continuing to come back to this theme that I think we have, which is like, how do we explore two hypotheses in parallel? Like early on, there was the heart failure hypothesis given the risk factors, but then also walking forward potentially from the outset, the possibility of a drug toxicity as well. Cause like not in the same way that I have heard some great pulmonologists say not all that wheezes is asthma, not all that crackles is pulmonary edema either. So I think this case really emphasizes that. All right.
Beautiful. Thank you so much, Deborah. You're awesome, my friend. Hans, Reza, I'm such a big fan. Jack, you're amazing. And Gabrielle, we can't wait for the teaching points.
Thank you, guys. That was an awesome case, and I love for your comments, guys. Such a great discussion. And this case remind me that on the Monday episode, Sukriti put us in a chat an article of the heroism of a very nice New Yorker article of the heroism of incremental care. And there was a story of a woman that presented with rare face edema that was progressing over the days and expanded into the chest and the hands. And the doctors didn't know what was causing that. And after 2 weeks, the patient recovered, and the answer was that she ran out of naproxen, which was causing all these side effects. So it's very important to keep the medications in the background of our minds. So for starting the teaching points, first, we were approaching the shortness of breath and cough, and has Jack divided into 3 big categories: the cardiovascular, the pulmonary, and the extra cardiovascular pulmonary system, such as ventilation mechanic defects or systemic conditions. And also Jack was teaching us about how to move forward. So for example, if we see signs or symptoms of volume overload, we should look for cardiovascular pathology, or if there's signs or symptoms of systemic inflammation, it points towards a pulmonary pathology. But if we found neither of them, we have to collect more clues, for example, in the physical exam, imaging, and labs. And then Charmaine and Teresa were working that and gave this amazing idea that the cardiovascular system in this case is less likely because we didn't see evidence of fluid overload, but only the bilateral crackles, and also it was basically a normal cardiovascular exam. So the heart failure did not explain all this symptomatology, taking into consideration the law of proportionality that Rabbit teaches us. Also, we separate then what can explain all these pulmonary coarse crackles. If this is through water, the heart failure does not explain of these symptoms. If it is a blood, this could be a diffuse alveolar hemorrhage of this spas. We have to keep in the background atypical pneumonias, but for example, viruses, Legionella, or fungi. And in the category of cells proteins, there are certain autonomic conditions such as sarcoidosis or malignancies, and also taking into consideration the amiodarone medication of the patient that can induce pulmonary toxicities, which was the final diagnosis. So thank you so much for connecting in, and see you tomorrow.
Bye, everyone.
Woohoo! That was awesome, Gabrielle. Thanks, Antonio, for scribing too. Until tomorrow.
Bye, team.